Hello and welcome. Today we have a conversation with two medical experts who are going to tell us how to deal with the current COVID times. The first is, of course, Professor Srinath Reddy. He is a public health expert and also part of the high-profile ICMR team that is probing into COVID and the president of the Public Health Foundation India. After that, we'll also be having a conversation with Harsh Mahajan of Mahajan Imaging. But first, Professor Reddy. Professor, I would welcome you to this show, public health expert, sorry. And first of all, I would like to begin with, putting us, can you tell us exactly where we stand in the fight against COVID? How soon do you expect a vaccine? Where are we? What have you heard?
Well, as far as the fight against COVID is concerned, I think it's a continuing fight. I don't think we are going to see the virus disappear before the middle of next year. That may be the earliest in terms of posing a challenge. When I say disappear, I mean in terms of being a major threat. Of course, it's likely that the virus will continue its existence on this earth and will continue to visit us seasonally. But in terms of the severity of the threat it poses, it's likely that at least till the middle of next year, it will continue to be a problem. In terms of the vaccine, well, basically the announcements from various public health agencies as well as from the various companies who are producing the vaccines and testing them in trials, they are claiming, some of them, that they will have the vaccine available in terms of presentation of evidence by the end of the year, and then it will be market ready by somewhere in the first or second quarter of next year. But that still awaits an examination of the evidence to see whether safety and efficacy criteria are adequately met or not by the regulatory agencies. So we still have a question mark on the vaccine, and we have several candidate vaccines. Many of them have the requirement of 2 doses. There is one vaccine which is promising only a single dose. So we'll have to see which of them becomes a winner, if at all, any one of them becomes a winner. So there are a lot of question marks still on the vaccine.
Then that leaves us to the other option, herd immunity. Where are we on that? I'm reading various figures, 30%, some people say lesser. And do people who have COVID get a relapse?
Well, herd immunity is a concept that is a bit nebulous because it assumes that those people who have antibodies are likely to have immunity, which is going to be long-lasting for some time, at least. We now know that from the serosurveillance studies that different cities are showing anywhere between 17% to 30% antibody positivity. But apart from the fact that antibodies can sometimes have cross-reactivity to other coronaviruses like common cold viruses, and these false positives get greatly amplified when you transfer a test which has been validated in the laboratory to the field settings, because there is a mathematical reason why the false positives tend to get magnified that way. So we cannot be 100% sure that 30% means 30% and not 20%. But even more importantly, assuming that it's 30%, are these antibodies neutralizing antibodies or not? Unless these antibodies are capable of binding to the virus and paralyzing it in terms of holding it till the killer T cells come and kill it, we are unlikely to be sure that there is immunity really. So firstly, we are not sure how long the immunity lasts. And the other major principle that one must understand is that this is not really herd immunity, it is herd protection. Let me explain
the difference, yeah, please.
Let me explain that. Well, let us assume that in Delhi, 60% of the people are infected, recover, and become immune. The threshold, which is called the herd immunity threshold, previously was estimated to be 60 to 70%. Now some people are saying it could be 40%, but let's say 50% for the sake of argument. Now, if 50% of the people are infected, recover, and are immune, their bodies are preventing the circulation of the virus to the other 50%. They are providing a protective cordon blocking the virus from reaching the others who are not infected and therefore not immune. Now, if any one of those people step out of this protective cordon, if they travel to Raipur or Ranchi or somewhere where the infection rates may have been only 10 to 15%, they're no longer protected. So from one zone in the city to another zone in the city, one part of the country to another part of the country, one country to another country, there is really no protection unless each population segment has reached that herd immunity threshold. Now, for all of India to reach that 50% threshold or 60% threshold, or all of the world to reach that threshold is going to take a long time. Therefore, to pin our hopes on herd immunity is a bit of an elusive hope, I would say.
Doctor, you're not a gambling man, but then what would you pin your hope on?
Okay, so let us look at 3 fire escape routes. One is the vaccine, which we have discussed. It's possible that we may get a potent vaccine, and even if the protection lasts only for 6 months, that may still be enough to protect the susceptibles and to break the chain of transmission. So we have to keep that as a possibility, never as a surety. But the second, herd immunity, I've mentioned, we'll certainly get herd immunity, but maybe 2 years, 3 years, maybe 5 years, but not within 6 months, no way. So, but the third possibility exists, which is what I would call evolutionary biology. By that I mean, the viruses, when they are in the wild animals or the forestry, tend to be relatively quiescent. They don't kill all the primary host, the wild animal, because if they do that, they lose the chance for propagating their own species. They become extinct themselves. On the other hand, when they enter the captive veterinary population, which is large, or the human communities who are very large in size and travel very fast and far, then the virus can actually spread fast and can become more virulent without running the risk of extinguishing its own species. But after a certain time, each virus reaches a certain threshold where it recognizes that it has to become a little milder if it has to coexist with humanity, because it cannot afford to wipe out its host. Other viruses too have behaved that way in the past. So some of the coronaviruses that we see now floating around may have been very virulent when they started. But it is very likely that the virus also will, over a period of time, change its nature. When is it going to happen? What are the triggers that will make it happen? We do not know. So there are all these 3 possibilities exist, but till one of them fructifies, we have to remain on guard with our physical distancing, with our masks, and ensuring that large crowds do not gather. Because one of the critical messages that is not yet registered to people is that 80% of the cases arise from 20% of the people. And that's not because people are very distinctively genetically different. Quite often these are because of super spreader events. If I'm an infected person meeting only 1 or 2 people, I infect those 2. If I'm sitting in a crowd of 30 or 40, I'll infect many more. So it is the super spreader events that have to be definitely curbed. And that is where the political will is also required to ensure that the civic administration does not allow those kind of gatherings to happen. And personal discipline is also important for us, not to go around in shopping sprees or gather in crowds in indoor offices.
We're hearing rumors of a second lockdown. Do you see that as a possibility? Would you recommend that?
I don't think so. Basically, I believe we have gone very well past the stage of lockdown. Even in the first instance, I think we should have had a selective lockdown. We need not have had a countrywide lockdown. But having said that, right now, given the fact that we do need to resume our economic, social, and scholastic activities, and that there is also a differential spread of the virus across the country in different time periods and different rates, we cannot have a lockdown as a national or even a statewide activity. On the other hand, micro-containment measures can be taken in selected wards of cities or selected villages if need be, based on the local assessment. It is entirely a sub-district level judgment that has to be made. It cannot even be a state level decision that should be made.
So to make this decision, we need to ramp up our testing. Are you satisfied with the level of testing, or do you think there's still a huge gap?
Well, I think it's more than the testing itself. It is our testing methods and testing targets that need to be really looked at. Let me make one thing clear. Testing is needed, but testing is only one part of the armamentarium of public health for containment. If you look at the United States, it has tested much more than anybody else in the world in terms of testing rates per million, and where is the US? And compared to that, Canada has done much better. Many countries which have tested less have done much better. Virtually in no geographic zone of the world is there any correlation between the testing rates per million and death rates per million. However, containment does require case identification and testing. And that is where we have to detect the cases early, suspected cases early, by home surveillance, symptom-based home surveillance, as well as contact history. If we actually have our primary healthcare teams very energetically going to every house and asking people whether they have any symptoms suggestive of COVID, and immediately get them tested early, and then trace the contacts, even if it's a local contact tracing, then we'll be able to actually contain it much better. Secondly, we ought to choose our testing methods much better. The rapid antigen test has several false negatives. It has some uses, but you cannot use it ad lib and say that, that is helping us to identify cases when it's likely to miss 50% of the cases. So we have to actually combine our assessment of contact history, our assessment of the symptoms, our assessment of the test result into a composite assessment of whether a person is affected and is likely to be infectious. Just looking at testing alone as the strategy would be very short-sighted. Testing is needed, but use it wisely.
And what about the treatment protocol? Can you just help our viewers, simplify it for our viewers as to what one should do really? What really you think works best?
Well, it appears now that mild cases do not really require any active intervention and they can benefit from home care. But certainly, given the fact that there can be sudden deterioration, one has to actually not only measure the temperature, but more importantly, keep measuring the oxygen levels in the body by the pulse oximetry. If one can purchase a pulse oximeter, fine. Otherwise, primary healthcare teams should visit homes and daily check people for their pulse oximeter, by the pulse oximeter for the blood oxygen levels. And if there is a deterioration either of clinical status or in terms of the pulse oximetry levels, then they should be taken to the hospital without much delay. In the hospitals itself, it's now very clear that our initial impression that ventilators are going to be extensively required has proven false. Very small fraction actually requires or benefits from ventilators. So on the other hand, even people who require intensive care benefit from two things. One is called active proning. If people are made to lie on their belly, they are much more likely to improve their blood oxygen levels. Second is continuous high flow oxygen. Those people whose oxygen doesn't improve on active proning can be put on continuous high flow oxygen, and that seems to improve. Only those who do not improve on either of these should then possibly be considered for a ventilator intervention. But it's very likely that a very large number of people can actually take home care and then improve rather than rushing to a hospital. But we still do need our health services to be fully geared up for home monitoring, early emergency transport, and prompt and proper care in the hospital setting.
And, there have been a lot of queries, speculation as to can you get a COVID relapse and, how long does the immunity last?
Well, actually, the evidence is gathering. This is a new virus and it likes to throw a surprise every week at us. Now, as far as the reinfection is concerned, the first case that was discovered in Hong Kong basically was asymptomatic. He had just returned from a trip abroad. In terms of the second instance, and it was purely by chance on airport screening that the second infection was detected, and the person was really asymptomatic and didn't have any clinical features. But then in the United States, there was another case that came up which did have symptoms even in the second instance, and now we are having some reports from India and that in the second instance, 4 cases had actually shown significant symptoms. So we do not know whether a person's overall immune status and the level of immune response that has been built up in the first infection is adequate to protect against the second infection or to protect against severe manifestation of the second infection. And that seems to be variable. Whether it's because of different virus strains, we cannot say, but very likely because of different immunological response. And also the virus load. one of the problems is that if there are doctors and nurses repetitively exposed to high virus loads from many patients, then that will overcome their body resistance. I mean, after all, the immunity can only fight that much of a viral load at a time. So, therefore, the reinfection is more likely in such people, and that's what we have seen in India. So, reinfection may occur, may have some clinical consequences, but is likely to be very, very limited. Not many people are likely to suffer the consequences of reinfection because, fortunately, our immune system has what are called memory T cells and memory B cells, which, even if the immunity goes down temporarily, it has the recall phenomenon. I mean, just like the pictures of criminals are kept in the rogues gallery of police stations, the body immediately recognizes, oh, this is the old criminal, and then mounts a defense immediately. So we have that facility.
And one more question is, we've also had a chance to study post-COVID patients. Are we seeing them to be more vulnerable, or what are the post-COVID complications that you are facing, that you're seeing?
Yes, when this particular virus came in, it was felt that either it will kill or have people recover within 2 weeks or so. So it was seen as an acute illness, never as a chronic illness. And now we are seeing evidence of what's called long COVID or chronic consequences of COVID. Many people complain of fatigue, and that seems to be the least of the problems. But we are seeing lung fibrosis, we are seeing the muscle fibers in the heart being damaged either by the virus itself, which seems to be clean cutting the muscle fibers, or by the immune response. The body's own immune response sometimes can actually damage many tissues in the body. So we are seeing many areas affected. Even the brain is affected now, we are learning. And apart from the fact that there are clots that form across the blood vessels, both in the veins and the arteries, and they can cause severe organ damage. We are even seeing reports of diabetes because of pancreas being damaged. So this virus is not confining itself to the lungs, though it goes by the name of a respiratory virus. Just as it wants to roam around the entire world, it is also capable of roaming around the entire body and affecting most tissues in the body.
The brain is infected. What are the complications that can happen?
Pardon me?
You said the brain can also be affected. So what are the
Firstly, the brain can be affected because the simplest thing that happens is that the virus can travel along the olfactory nerve to the olfactory bulb and then result in a loss of smell. But more importantly, it can also go through a plate called the cribriform plate, which is there, which lies at the base of the skull, and then affect the brain itself. It can also, while circulating in the blood, cross the blood-brain barrier and affect the brain. So what's called encephalitis or inflammation of the brain can occur. There can be delirium, and there can be loss of cognition. I mean, there can be many brain functions that can be diminished as a result of this. And we are learning more and more about this as we go along. Fortunately, these are seen only in a minority of patients, but they do occur, and that's a cause for worry.
And is this a permanent thing, or is it a temporary phase?
Again, it's very difficult for us to say because this is a fairly recent virus, but some of the damage does appear to be permanent. Because if you have fibrosis in the lungs, if you have myocardial damage of muscle fibers in the heart and in the brain as well, some of the damage will be permanent. Unlike the liver, which can repair itself, the heart muscle cannot repair itself. So there will be some areas of the body where the repair can take place, but there are some areas in the body where the damage can be permanent.
As we end, Professor, any advice for my viewers as to how to go about the next, say, 8 months at least, if not more?
I say we must follow the 3C formula: care, caution, and confidence. Care is, do take personal care, wear your masks, keep hand washing, and when you go out, observe physical distancing. Avoid crowded areas. If there is a crowd that you have to walk past, then walk past briskly so that you don't have a long-time exposure. Avoid crowded shopping areas. Avoid crowded indoor areas. That's the caution part of it. and even public transport, try to minimize the crowded transport. And we can try and see whether we can stagger the work times and school times so that even the public transport is not overloaded. Then the confidence part of it is, well, this virus is going to be with us for some time. Hopefully it will change its behavior. But we have to make sure that we get along with our minimal required life activities, whether it is economic or social or scholastic activities. So we proceed with that caution, because if we are very anxious and very depressed, that also undermines our immunity. But the most important thing is try and behave with a certain degree of care and caution. Because unless we change our behavior, the virus will not change its behavior.
Really a lesson from Sun Tzu's Art of War, I think, as to how to face the virus. But thank you, Professor Reddy, for taking time out from your busy schedule. And more importantly, I feel for explaining it to us in very simple and layman terms. That's really worked well for all of us who are not really medical experts, but have to grapple with this. Thank you so much for talking to us. Well, and now we're joined by Dr. Harsh Mahajan. As I mentioned earlier, he is the chief radiologist and also the founder of Mahajan Imaging. Welcome to this conversation, Dr. Mahajan. And you've been someone who's been... Thank you for joining us. And you've been on this since ground zero since day one, I would say, really. So can you just take us through where we started from and where we are now in terms of testing diagnostics?
See, when we started, and this is end February, beginning March, the whole of the country was capable of probably doing only 1,000 tests for COVID-19. None of the kits were made in India. From there, we have reached a stage where consistently we are doing over 1.1 million tests a day. That's a huge number if you look at any country in the world. Also, it's very heartening that many of these kits are made within the country. They've been developed
my next question.
in this short span of time. And in fact, our capacity is such that given the opportunity, our manufacturers and our companies within the country would like to export them outside. And this I'm talking of the state-of-the-art, gold standard RT-PCR test. In addition, of course, many other tests have got built also, which we'll talk about as we go forward.
In fact, can you tell me the various tests that are there and what are the pros and cons? You know, there is the antigen test, there is the RT-PC test. Are there any more? What would you advise? Can you talk us through that?
Basically, the tests can be put into two categories. One, which diagnose the illness itself, COVID-19, and two, which show us whether we've developed resistance or immunity to the illness after having had the infection. So in the first category, basically there are two tests, the gold standard RT-PCR test, which is, the highest level of sensitivity. And this is what across the globe, when you go country to country, this is what is relied upon and also is the most sensitive and specific test. And this is a test which is done in a lab. It requires a certain infrastructure. It requires expertise of people who are running the test. And it requires specific machines to be able to do it. And apart from this, we have the rapid antigen test, which has gained a lot of popularity ever since June when it was introduced in Delhi. This is a test which has low sensitivity, around 50%, but is a point of care test, meaning you can do it right at the place where you're taking the sample. For both these tests, you need to take samples through the nose and the throat and then test. But the advantage of rapid antigen test is that right there and then within 15 to 30 minutes, it can give you the result. So the
results are not very accurate.
It is not very accurate. It tends to miss positives. It is said that for every 2 people who have the infection, it's going to miss 1. So that's the disadvantage of this test, that we may let positives go through the sieve and they go back with a negative report and hence may help in spreading the disease more. But the advantage is that once you've caught a guy right there and then, you're not waiting 24 hours or 8 hours or 48 hours for the report. Right there and then you catch the guy, you find out about his contacts and you can do good contact tracing. But the disadvantage is that a lot many will go away with a negative report, whereas they have the disease. The third, and let me come to that, is the antibody test, which is again, there was a fiasco in the beginning when we got these Chinese kits, which were rapid antibody kits, point of care kits, but they were very, very bad, 5-10% accuracy. And so those were sent back. But we have a South Korean company which developed an antibody kit, which is to be done again in the lab. But this is a sample of blood that is taken. So you're not exposing the phlebotomist to the infection with, so a patient will wear a mask and you take a blood sample. So the chance of getting the disease is much lower. This antibodies actually determine and show you whether you have had the disease and how much is your immunity. Again, we know very little as yet about antibody, and it is said that 30 to 50% of infected people may not develop antibodies. But as time goes by, we will know more about it. But this is a test which is useful in its own setting and is very useful for doing sero surveys across community. And this have been done by ICMR, they've been done by various state governments. And they have led us to believe that actually the infection is much more prevalent in the community. Many more people have had the infection than the diagnosed cases, which may vary between 30 to 80 times the number of people. So if we say 1 lakh people have developed the infection, it may actually be based on these sero surveys, if they are to be believed, that it may be 30 to 80 lakh people who had the infection.
Doctor, one more question. When is a good time? When does one get tested? Because, we have a thing, if you, like, for instance, if a person comes from abroad, or even if like my maid goes out to her home in Bihar and she comes back, do I test her the first day? Do I test her after 10 days? Because a lot of symptoms take a little long to develop. So when should one test a person?
This is a great question. And this is a question we get asked every day. And thanks for bringing it up. See, the incubation period of this virus for someone to get disease varies between 2 to 14 days. The average is 5 days. Okay. So I would say if a maid or anyone has come and has traveled on a train or by air or whichever means, by bus, and now come to your home, I would say you need to isolate them first for the first 7 days. Isolate them in a separate room where they use a separate bathroom also, because they may have contracted the disease during the travel. This is what we have to presume, that it may happen. So 7 days, and on the 7th day or the 8th day, you can run the test, because the chance of getting a positive report in case someone got it during travel is fairly high. Some people say do it on the 5th, 6th or 7th. I would say do it on the 7th. And if that comes negative, ideally, you would still want to wait 14 days, but most people don't do that. But you can bring her into the home on the 8th or the 9th day and pray that she's not someone who's going to have a latent period of 10, 12, 14 days. I think you would do well in most instances. But if you have elderly people at home, if you have others who may be having comorbidities, then a 14-day period would be best. But in any case, once she comes into the home, she should always be wearing a mask, and hand hygiene should be immaculately followed. Social distancing in the home may not be possible, but do try that also. So we have to be cautious throughout this time.
Last question is post-COVID complications, because I'm sure everybody is rushing to you for the diagnostics. What are you seeing? Where are the areas that are most vulnerable? Are people developing complications with lung, with the brain, with the, what is happening in post-COVID?
See, the majority of people are, of course, having lung complications. Out of those who do have it, this, I would say, is still not a very virulent disease. Because if you look at the asymptomatics, those are huge. But lung complications, lung fibrosis to lesser or larger extent, lesser lung fibrosis may not even reflect clinically. But when someone persists with breathlessness and the lesions are persisting, they may be active, or it may be that as a part of the healing process, there is fibrosis, and that we hear of these anecdotal cases across the world where even lung transplants have been done. The heart is said to be affected in a large majority of people, even those with mild disease. There's a paper out of Germany which says that they did MRI in 100 recovered people, and in 78% they found abnormality on the MRI. How this will reflect in terms of arrhythmias or other cardiac diseases, only time will tell. It's been only 6 to 8 months as yet. Then there are cases where there have been strokes, where there have been gangrene. This disease we know does affect the arteries and the blood vessels. And because of that, inflammation in them, it can cause pulmonary thromboembolism also, which can be life-threatening. It can cause strokes, all those things. But that is happening, luckily, in a minority of patients, because our doctors in these 6 months have also learned the tricks of how to treat this well, when to start steroids, when to start remdesivir, when not to put on a ventilator. So there's been huge learning that has been contracted into a short period of time, and this is going to stand us in good stead. And if you see, we learned from what went wrong in the West, because we got the infection about 2 months, 1.5 months later. We learned from what they learned, and we are amongst the large countries, the ones with the lowest case fatality ratio. And if we look at the infection fatality ratio, that's very, very low. So we have learned from each other, and this is something which is helping our patients get better fast and not have serious complications.
Thank you, Dr. Mahajan, for sharing this with us. And, we hope to get you back for a longer chat sometime soon. But for now, thank you so much.
Thank you very much for having me.
Pleasure having you.
For more such videos, subscribe to the NewsX YouTube channel, hit the bell icon.